Hello, everybody. My name is Andy Catcher. I'm the Media Communications Director here at NOFAS, the National Organization on Fetal Alcohol Syndrome. And thanks to everyone for joining this NOFAS webinar on preventing secondary conditions in people with FASD, presented by Christie Petrenko, Ph.D. She's a research psychologist and assistant professor at Mount Hope Family Center, the University of Rochester. And she's going to be presenting on preventing secondary conditions in people with fetal alcohol spectrum disorders for about 40-45 minutes or so. And then there will be about 10 or 15 minutes available for question and answers. And you should see a little window on your screen to type in a question. So feel free to type in a question at any time. And after the presentation, I'll come on and ask aloud some of the questions that were submitted, as many questions as time permitting. Also wanted to let people know that the webinar is being recorded, and a video of the recorded webinar will be available on the NOFAS website within 24 hours. At nofas.org on the homepage, there is a button for webinars, and the recorded webinar will be posted on that page, as well as the NOFAS YouTube channel. So, a short introduction. Christie Petrenko is a clinical psychologist and researcher. She's been conducting research with individuals with FASD since 2003, and she completed her graduate training with Edward Riley and Sarah Matson in San Diego, and is currently a faculty member at Mount Hope Family Center, the University of Rochester. Her research focuses on the efficacy of interventions aimed at preventing secondary conditions, and she also runs a multidisciplinary FASD clinic providing diagnostic and intervention services. So at this time, I'll turn the presentation over to Christie.
Great. Thanks, Andy, for the introduction. I want to start by thanking Kathy Mitchell, Tom Donaldson, and Andy Catcher at NOFAS for inviting me to present today. Secondary conditions are an issue of utmost concern for people with FASD, their families, and providers. My goal today is to share with you current research on this topic and begin a discussion of the types of services and supports that we can put in place to prevent or reduce the impact of these conditions on people's lives. Oops. Hold on, I'm having a momentary technical difficulty there. All right, I think we're set. So let's start by first remembering the importance of recognizing the whole person. It is easy when thinking about secondary conditions to feel overwhelmed or see the future as bleak. However, I think it's important to try to recognize the whole person and consider not only the risks people face, but also the protective factors and unique strengths and characteristics people have to contribute. We also need to remember that prenatal alcohol exposure may not be the only risk factor that children and adults with FASD have faced, and not to over-attribute its causal role. It's essential to try to see the big picture. This is especially important when thinking about intervention. A colleague of mine often uses the metaphor of an onion when thinking about risks and resilience. Not only the different layers, but also this common saying about an onion can make you cry, but it can also add wonderful flavor to life. So this slide here is to remind us that we are talking about a spectrum of disorders that can impact people in different ways and to varying degrees. I have highlighted here the different features that are impacted for the different diagnoses on the spectrum, but you can see that neurobehavioral impairment is present across all three conditions, as shown in the green. So let's dive in. First, what are secondary conditions? In order to define secondary conditions, we first need to understand the primary disabilities associated with FASD. Primary disabilities are the neurobehavioral impairments associated with alcohol exposure on the developing brain. Areas commonly impacted in FASD include intelligence, executive functioning, attention, processing speed, memory, and social communication as examples. So secondary conditions are conditions that can develop when people's primary disabilities are not well supported. So I'm going to start by showing data on secondary conditions from a large clinical sample studied by Streiskuth and colleagues in the mid-1990s. We'll then talk about factors that increase and decrease risk for these conditions, and different models for how these conditions may develop over time. So here, the different color bars reflect the rates of lifetime history of each condition by the child's age at the time of interview. And so brown bars reflect school-age children, blue are adolescents, and orange are adults. As you can see, mental health problems are prevalent across the lifespan. These include things such as ADHD and other disruptive behavior disorders, mood disorders, anxiety disorders are common. Other conditions such as disrupted school experiences, trouble with the law, confinement in inpatient or mental health or justice systems, and drug and alcohol problems increase dramatically by adolescence and adulthood. Streiskuth and colleagues also identified some factors that increased risk for secondary conditions. And these include things like age, like you saw on the last slide, being a victim of abuse or violence, frequent changes in households, a higher level of behavior problems. As you may recall also from the graph, not everyone had secondary conditions. Protective factors were also identified, including having an early diagnosis before age 6, having a diagnosis of full fetal alcohol syndrome versus another FASD, having a lower IQ, receiving appropriate developmental disability services, and having a stable and nurturing home. It might seem a little counterintuitive at first in thinking about having a diagnosis of full FAS or a lower IQ as being protective, but my hypothesis is that these factors make it more likely that people recognize that you have a disability and putting appropriate supports in place. So our goal with interventions is to reduce or mitigate the risk factors and increase protective factors that we are able to change. So now let's start talking about how secondary conditions are thought to develop. So Diane Malbin in her book, Trying Differently Rather Than Harder, presents the following model. So first, people with FASD often have gaps or days where they're doing well and days where they are not doing as well, or on and off days. You know, on those days where they're having an off day and they aren't able to do a specific task or behavior, it's often easy for people to interpret willfulness, not necessarily of malintent or things like that, but often it's people don't know any different and they have these automatic interpretations. And if you interpret willfulness, it's not unusual to utilize punishment or a consequence approach. And this often leaves people with FASD feeling angry as well as the adults. And over time, you can develop increased reactivity. And so across various settings and over time, you can get an escalation and increased difficulty in coping. And many of the secondary conditions really reflect the person with FASD having difficulty coping with their situation. So next, I will present a model I developed after interviewing several young adults with FASD, as well as viewing firsthand videos and books published by adults with FASD. My goal was to try to understand the experiences of young adults who have FASD. And in this analysis, two main pathways emerged. The first reflects difficulty coping, and the second reflects overcoming the disability. So difficulty coping meant struggling often with secondary conditions. These young adults experienced teachers and other adults as not understanding their disability and were vulnerable to negative peer influences because of either positive peer rejection and a strong need to feel accepted. These adults often had strong parental support and advocacy, but this support was not always enough to buffer these experiences. Many were only able to access appropriate services after struggling, and it often took multiple attempts of service engagement for them to overcome secondary conditions. Overcoming the disability ultimately meant feeling successful, accepting oneself and the disability, and wanting to educate and help others learn about FASD. All of the young adults who felt they had overcome their disability also described strong parental support and advocacy and receipt of appropriate services. I think the concept of feeling successful is really key here. We really need to strive to help identify the talents and strengths of young people with FASD and often create opportunities for them to realize these strengths and interests and talents. Also, as you can see, individual and contextual factors across the lifespan also influence adult pathways. For example, young adults with more severe FASD symptoms are more likely to qualify for services and be recognized as having a disability, as we previously talked about. Also, an earlier age of diagnosis is related to better outcomes. Having histories of maltreatment and multiple placements were associated with greater difficulty in coping in young adulthood. So, what does this tell us so far? Secondary conditions occur at elevated rates in FASD, especially by adolescence and adulthood. They often represent or result from people not understanding the disability. There are factors that increase and decrease risk, and importantly, some of these factors can be changed. Family members and service providers play a large role in promoting positive outcomes, and people with FASD need to feel successful, just like anyone else. So this is a good start to help us figure out what to do to prevent secondary conditions and support people with FASD and their families. Before delving into developing an intervention program, I first sought to gain wisdom of caregivers and providers as part of a qualitative research study. I felt this was an important step to more fully understand what was available in my region, what the barriers were, and what people felt was needed. You don't want to develop a grand intervention no one wants or needs. So resources are scarce, so you also want to set things up to have the best shot possible for success, which was ultimately what I was trying to accomplish with this study. So in this study, we conducted interviews and focus groups with a variety of parents who were raising children or adults with FASD from a wide age range of 3 to 33. And also a variety of service providers, including pediatricians, neuropsychologists, FASD educators and advocates, child welfare workers. The only group that we didn't really get very well in terms of service providers was classroom teachers. However, we did have some educators and advocates who had had experience in the classroom previously. And in these focus groups and interviews, we asked the same kinds of questions. We included questions such as to get at the strengths and challenges of people with FASD. We also were interested in the strengths and challenges of caregivers. We wanted to also spend time thinking about the age range and areas that we would want to target for intervention and prevention. So we asked parents to brainstorm ideas. Who should we intervene with, what, when, where, and how? We also spent time talking about the duration of intervention and the types of incentives and obstacles that would encourage people to participate. Next, we spent time analyzing data. The analysis was systematic. We transcribed verbatim everything that was said in these interviews and focus groups. We looked at transcripts multiple times, looked for themes and key concepts and how they were related. We then spent time organizing the data, and essentially we wallpapered a conference room, as you can see here with my assistant. This was actually just about half the data. And then we really kind of essentially asked the data questions. We thought and asked, does the things that people said differ by the age their child was or the profession that they were in? And we looked for evidence that either confirmed or disconfirmed our ideas and models. The themes from the parents and the providers were pretty similar and they didn't differ significantly, so we combined them for analysis. And then after we had kind of put a model together, we went back to the parents and asked them to verify that what we had put together really represented their opinions and experiences. So 3 manuscripts or papers have come out from this study, 2 of which are already published and the third is under review. And these studies, at least the first 2, are in the public domain, so you should be able to access them. They were all funded through the National Institutes of Alcohol Abuse and Alcoholism, so if you search for them, you should be able to find them. And I will walk through the results of each of them. So in the first study, we focused on understanding the systems level barriers facing families raising children with FASD that really interfere with families being able to prevent secondary conditions. This is the topic that families and providers wanted to talk about most during the interviews and focus groups. Many families I spoke to had a sense of what their child needed, but ran across barriers in their attempts to acquire and the appropriate knowledge or access to services. And so these barriers included, for example, the first was delayed diagnosis. Many people had difficulty finding providers who were knowledgeable to diagnosis, or even just to lead them in the right path to get a diagnosis. Many people in our sample were diagnosed later, or had some real struggles in getting the right answers for their family members. Once diagnosed, it was often difficult to qualify for services. Particularly, families talked a lot about the special education system or developmental disability system. There isn't a box for FASD, so it was hard for them sometimes to meet the criteria for these systems. Also, there was a real lack of FASD-informed services that were available in our community, and so it was often difficult to get those things met, those needs met. And then when services were available or provided, families often had difficulty making sure that they were implemented consistently or maintaining them over time. Particularly, most families were talking about the school system in this regard, and making sure IEPs and things were followed. And then many children, once given effective accommodations and services, could be successful, but once they were successful, there was this push to try to remove them. So many of these barriers were fairly significant for families, and they were really all associated with kind of a significant limited knowledge about FASD across the systems as well as in the broader community. Next, we also sought to understand caregivers' experiences. Caregivers identified systems barriers often contributed to the development of secondary conditions in their children. They implemented persistent protective actions to try to support their children's primary disabilities and overcome systems barriers. These actions included self-education, such as for those parents on the webinar today, listening to webinars, going to conferences, reading books, just trying to learn as much as you can, connecting with other parents. Also advocacy, really, trying to get their kids' needs met in the best way they can. Often, caregiving for people with FASD requires creativity and thinking outside the box. Many of the standard approaches don't seem to be a great fit for people with FASD, and trying to be as patient as one could be. However, many of these actions can contribute to increased emotional and practical stressors. In addition to feeling of stress and worry, parents often talked about the isolation and stigma of having a child with disability or significant behavior problems. Also managing the practicalities of appointments and challenging behaviors and trying to just manage everything their child and family needed was often very difficult and stressful at times. Parents also described a number of common themes that help them sustain their drive to persevere, such as, just a devotion and unconditional love for their child and really wanting to see their child be successful, and just really trying, it's their children, they really want to try to see the best for them as they could. We also spent quite a bit of time in this study discussing the ideal characteristics of interventions to prevent secondary conditions. And 5 main themes emerged. The first is that interventions need to be available across the lifespan. One participant even said, from cradle to grave was her quote. Interventions also need to take a preventive or proactive focus. Rather than being reactive, families really wanted proactive, anticipatory guidance. Many felt that they had to wait for their children to fail to access services. They wanted to know what to consider for different types of services or supports for their children at different age points, especially at key transition periods such as school entry or transition to adulthood. Interventions also need to be individualized. Child and family needs vary quite a bit, and so programs need to be responsive to this. Also, intervention services need to be comprehensive, need to consider the whole child and address multi-problem issues. Many of these children also have experienced a range of postnatal experiences, including trauma, and these need to be taken into account. And ultimately, services need to be coordinated. Many people with FASD are served across various systems, and it can be difficult for families to navigate these systems. Often, there isn't a central figure that can really coordinate these for them, and so families do a lot of running around trying to get needs met. These characteristics are consistent with a positive behavior support framework, which is a useful way to start thinking about this. Also, here's a visual of the types of concrete services and families and providers envision. I know there's a lot going on here, so I'll kind of walk you through it. But ultimately, services and supports need to be available for people with FASD across the lifespan, which is the lower group of circles. Also for parents in the upper right, and systems of care, as well as areas of overlap. So for example, parents talked about really needing support and encouragement from others who have been through the same thing. They needed resources to learn about FASD and to be able to respond to family resource challenges. They also needed help in advocating and navigating systems of care, how to have effective communication with providers, and ultimately respite. They also wanted anticipatory guidance and parent training resources, and help to know if legal guardianship was something that they should pursue. In terms of systems of care, there is a great need for education of school personnel, providers, and community members. Also, there needs to be an increase in access and availability for FASD-informed services, particularly increased diagnostic capacity and interagency coordination, which is a real limitation in certain areas. Also, improved ability to serve people with FASD within early intervention and school services, and greater assistance with vocational and transition planning. For people with FASD, in the early childhood period, folks recommended particularly targeting emotional and social skills, in addition self-regulation and areas of executive functioning, and ultimately finding those strengths and talents and interests in children and nurturing those. For older children, adolescents, and adults, things such as support groups and peer mentoring and counseling were raised, as well as a focus on life skills, and again, finding those strengths and talents and building on them. This model is very much in line with a medical home model with central coordination. And families really need someone to help guide and collaborate with them through the various systems and needs relevant for different developmental periods. Many systems in which these families interface have a coordinator or case manager, but this case manager, it's often not coordinated across systems and practice. And unfortunately, many times these folks don't have a lot of FASD training or knowledge. So now what? We know we need to educate people about FASD to reduce barriers. We know we need to start early to prevent and continue supporting across the lifespan. We also need to recognize the strengths and difficulties of caregivers and provide adequate supports, and involve the person with FASD, family members, and systems of care and intervention. We also know some specific strategies and services that might help. So how do we mobilize the availability of services and supports for people with FASD and their families? So this is not a one solution problem. We need to be doing lots of things. For example, local and national advocacy. We need families to be demanding supports and increasing training to providers. And also we need research to really document the efficacy of interventions and to provide data for policymakers to show the extent of the problem and what can be done. So now I'll transition to talking about a research study I conducted to try to address this last goal, which was to evaluate a multi-component intervention called Families on Track, which was largely informed by some of this prior research as well as other studies that have been done. So the Families on Track program is based on developmental psychopathology theory. Its aim is to help families and children develop and strengthen skills they need to adapt effectively to the transition period around school entry and early elementary school. It's thought that better adaptation at one stage puts people on a more positive trajectory for later developmental stages. So Families on Track is a fairly intensive intervention across 30 weeks, which is in line with the prior study that we talked about, that includes that intervention needs to be holistic and coordinated. There's multiple components to address the complex challenges that many kids and families face. Many participants in our prior study emphasized that intervention needs to start early. Many people talked about school entry might be a good time to intervene based on the most frequent ages at diagnosis and the types of learning and behaviors that often emerge around this early school period. But they also, of course, emphasize that these supports need to continue across the lifespan. So our family check-ins are really a first step in that direction. Check-ins help us identify needs for further support after the initial Families on Track program has wrapped up. Over time, it helps us also identify if there are common types of programming that might be useful at different ages and developmental periods. And so in this study, check-ins are completed mostly by phone. And then, if there's a home visit or consultation needed, we do that as well. So Families on Track is a multi-component intervention. And this first component I'll talk about is our parent component. It's the parent consultation. And the parent component uses an existing empirically validated program called the Families Moving Forward program. In this program, a specialist called the FMF specialist meets with the family in their home every other week, and they focus on helping parents understand FASD better. They do a positive behavior support planning process to help them figure out the most appropriate accommodations and responses to their children's behavior to really promote more adaptive functioning. There's also a focus on school advocacy and includes a consultation with the school team. They also really make an effort to help link the family with appropriate resources as well as social support and respite. And there's a focus also on self-care and really the needs of the caregiver as well as focusing on the child's behavior needs. We also integrated a child skills group program with the Families Moving Forward program, which is novel. And so the Child Skills Group program used the Promoting Alternative Thinking Strategies curriculum at the preschool level, which targets a variety of skills, including self-control or self-regulation, emotional understanding, positive self-esteem, relationships building, so peers, and problem solving. And groups met for about 30 weeks, so it met weekly, and included kids both with FASD as well as typically developing positive peers. And we taught skills through short lessons that are aided with puppets, multimodal activities, and intentional play to practice skills. We also focused on educating systems. So through the Families Moving Forward program, there's specific content on school consultation and educating other providers working with the family on FASD and really motivating them to want to learn more about FASD and to best support the child. We also did a number of lectures across university settings, agencies, and community organizations to really increase awareness and diagnosis and referral in this area. We also are involved with the New York State Interagency Work Group on FASD to try to coordinate efforts across the state. So in this study, we included children ages 4 to 8 in Western New York, which includes both the Rochester and Buffalo greater regions. For children with prenatal alcohol exposure and the full Families on Track, they had to have confirmed prenatal exposure or a diagnosis of full FAS or partial FAS if alcohol exposure was unconfirmed. We also included typically developing positive peers in our child skills group. So here's the study design. All families who joined the study received a full neuropsychological evaluation at the beginning of the study. Getting a neuropsychological evaluation in our community was challenging, especially with someone who was knowledgeable about FASD. So we provided full comprehensive reports to each family and gave feedback with individual recommendations and referrals. All families then also participated in a 2-hour research visit where we gave a number of measures that would help us evaluate the impact of the intervention on outcomes. Half the families were then selected to receive the Families on Track program, which was 30 weeks long. And again, parents had 15 sessions every other week, and children participated in weekly groups. Following the 30-week intervention, all families returned for an immediate research visit, and then again 6 months later, so that we could really measure to see if the intervention was indeed helpful. We also completed check-ins 3 times a year. I would call parents and see kind of proactively how things were going, and we would revisit any of the content from the Families on Track program to kind of help think about how to solve new problems if it was needed. And we hope to do some long-term follow-up as well as conduct a larger study. This was initially a pilot study. So we have also done a couple of descriptive studies based on some of the data we collected before the intervention started. One of the first studies that we did was to try to understand the strengths of children with FASD as perceived by their caregivers. I think this is an area that often doesn't get as much attention as it really needs. And so caregivers were asked to list 3 strengths of their children. And strengths, we ended up grouping them into about 3 categories that they kind of fell in. Nearly all parents identified a characteristic within the social motivation category, which includes things like loving, sweet, helpful, wants to please, thoughtful, friendly, makes laugh, just this desire to connect with other people. That seems to fit pretty well with clinical experience with kids within this age range of 4 to 8. There were a number of strengths highlighted relating to personality, such as being happy, funny, fun, energetic, adventurous, and curious. And then our specific abilities and talents included being artistic, smart, being a leader, being resilient, and determined. We also asked parents to describe the positive influence their child has on their family. Responses included like being taught, like the parents being taught important life lessons or new ways of thinking. Also the social benefits of spending time together and the emotional benefits of feeling joy or inspiration from the child and their family. Some families also talked about the child's role in the family that made their family complete, for example. There were some families who had difficulty identifying a specific positive influence and instead focused more on the child's individual strengths as reflected in the last slide. We were also interested in parent experiences. In this set of data, we interviewed parents about the types of strategies they use to manage their children's behavior. We also asked them to identify the most common reasons for misbehavior in their children. And then we analyzed the data in 2 ways. First, we did a qualitative analysis where we looked for patterns or themes in the words that parents used to describe their experience. We also analyzed the data quantitatively, or assigned numbers to different categories to test how parent attributions, or the way they interpreted their kids' behavior, related to the strategies they used. So this figure illustrates our qualitative analysis based on the words that families used and the patterns and how they talked about them. So I'll walk you through it. So first you can see on the left-hand side that families who had a greater knowledge about FASD and their children's disabilities were more likely to use neurodevelopmental attributions, or understanding their children's from a brain-based perspective. These families also described being more likely to use preventive strategies, or things like accommodations, such as changing the environment or how they said or did things with their children. These families also described feeling greater confidence in their role as a parent and having greater success in managing the behavior. Other families were more likely to make willful attributions of their behavior, mainly because they didn't know any other different way to think about it. These families were more likely to focus on consequence strategies, such as things that happen after the behavior, such as punishment or taking away privileges. And they often described feeling more ineffective and frustrated, and were ultimately less successful in managing the behavior, which often increased challenges. We also looked at the data quantitatively, so looking at correlations between variables, and generally they followed what we found qualitatively fairly well. I won't show all those numbers here because it gets quite complicated on the slide, but this paper has also been published and you can access that and read more about it yourself if you would like. So next I'll move on to talking about the results of the intervention. So importantly, how did parents like the program? Ultimately, this is a really essential question. So overall, parents had a high level of satisfaction with the program. We used a rating scale that had a possible of 32 points, and the average across all parents who completed the intervention was a 30.62. So generally, people really felt satisfied with the service they received. Caregivers also rated their experience and reported feeling positively about the specialists that work with them. They enjoyed the sessions and felt they could apply what they learned. They also rated the child's experience. They reported that most of their children liked going to group, that children learned some new skills, although they had some difficulty applying what they learned outside of group. And then here is a slide showing the change across a range of outcomes that I'll walk you through. So if you recall, we have two groups in the study. Both groups had a full neuropsych assessment and referrals to community services. Half also got the Families on Track program, and those are the blue bars. At first glance, you can see that overall, the Families on Track group showed improvements across a range of areas. The bars here are all on the same metric, and you can see the middle of the figure is at 0, meaning no change. 0.2 on either direction is a small effect, either a small improvement or a small worsening. 0.5 is a medium change, and 0.8 is a large change. The comparison group in red had some positive improvements, as you can see, but some areas also where things worsened or didn't change over time. So specifically, both groups, if you look at the very top of the slide for behavior problems, had a similar improvement in behavior problems. The Families on Track group in the blue bars had greater improvements for variables, for the child variables of emotion regulation, self-esteem, and anxiety, as reported by the kids. Parents in the Families on Track program showed large increases in FASD knowledge and felt that more of their needs were being met. They also showed important change in the idea of reframing or attributions, and were more likely to use antecedent strategies similar to what we showed on the prior slide that only looked at baseline data. So we showed that indeed families with intervention can improve on those areas and ultimately feel relatively more satisfied and effective in their role. Although this is a pretty small trial, results are promising and provide support for investing in larger trials to see if these findings replicate in larger samples. So what's next? I'll share a few of the future directions I'm working on, and then we'll wrap up for questions. So I've had the pleasure in collaborating with Heather Carmichael Olsen at the University of University of Washington in Seattle on research on the Families Moving Forward program, which, if you recall, is the parent component that we use in the Families on Track program. I want to share with two directions that I'm leading in our efforts to move the program forward to being deemed best practices and increase access to families. These directions include the replication and effectiveness study, as you can see kind of in the middle little sign, as well as a derivative program, which is an app that we're in the early stages of developing. So I'll share those with you next. So the Families Moving Forward trial, we're doing a replication effectiveness trial. Previously, Dr. Olsen had conducted a university trial and a community trial that had positive results. The Families on Track program also included FMF and found promising effects. An important thing that needs to be completed in order to increase the evidence base is an independent replication not done by Dr. Olsen. And so we currently have a trial of Families Moving Forward here underway, and are also collaborating with a site in East Los Angeles that also has been implementing the Families Moving Forward program for a number of years to look at multiple sites and see how the program is actually being implemented by clinicians and seeing if it is as effective as it has been in prior trials. But how do we get supports to people when there are a limited number of providers and agencies who provide FASD informed care? What else can we do? So we want to keep disseminating these effective interventions, but we also need to do more than that because we know that there is a real workforce shortage. And so one direction that we are just starting right now is to explore the effectiveness of mobile health intervention. So having an intervention that you can access through a smartphone. And as we currently envision it, this kind of intervention will include learning modules and content based on the Families Moving Forward program, and will also integrate moderated peer support. So self-help and peer support are approaches parents are already using, much like some of you today trying to learn from this webinar. And our goal is to develop an app that caregivers can easily use and test to see how effective it is for a wide range of families. So you might be thinking, what can I do? So if you're a provider, you can continue to explore opportunities for further education and training. You can also look into the SAMHSA Tip 58 on FASD informed care, both for resources and how to do FASD informed care for individual providers, as well at the agency policy level. There is also training available in the FMF program. At least several times a year, clinicians can get trained in this program and offer it in their communities. And there's a link in the website, or you could just search for FMF for FASD, and that should come up at the University of Washington site. So if you're a caregiver or an advocate for people with FASD, also continuing to explore opportunities for education and training is important. Also, it's very important to connect with others for support and mobilize change for your community. There are a number of groups and listservs that are available online, as well as in local communities that you can reach out to. And many of those are also listed on the NOFAS website within states. And what everyone can do is to really look for those strengths and interests and talents in people with FASD, because you will find them and they're there. And we really need to be creative in thinking about how to give people that meaning and success in their lives, because that is one very important thing to do for their ultimate ability to overcome some of their challenges. So I need to also acknowledge those who were critical in helping develop and evaluating the Families on Track program and some of the other research I've shared from our group. So first, the participating children and families who have been involved in this study and have given their time and input. Also our community partners in the area who have engaged with us and helping get the word out. The National Institute of Alcohol Abuse and Alcoholism funded this Career Development Award for me, and were instrumental in making this opportunity available. I had a number of consultants who are experts in the field who dedicated time and were generous, including Luther Robinson here at University of Buffalo, Mary O'Connor at University of California, Los Angeles, Claire Coles and Julie Cable at Emory, Heather Carmichael Olson in Seattle, and Heather Tausig in Denver. I've also had a lot of support here at the Mount Hope Family Center, University of Rochester, from senior faculty, as well as talented graduate students, research assistants, and undergraduate students. I also want to acknowledge Ed Riley and Sarah Matson, who first inspired me to look at the field of FASD and the continuing mentorship they've provided. And finally, I want to end by sharing this quote from a grandmother who participated in our program. She said, "A lot of the fears are gone. I'm so much more hopeful and optimistic, and I just feel like I've learned so much and it has taken off a tremendous weight." And I really wish this for all families raising children with FASD, that they can get the right supports and resources they need to feel effective in supporting their young people. So now I'd like to go ahead and open it up for questions. I think Andy will come back on and lead that discussion.
All right, thank you very much, Christy. Yes, again, this is Andy Katcher, NOFAS Communications Director, and we've had several questions that have come in. First of all, we had a question, somebody asking about receiving slides, a copy of the slides. So yes, those will be available on the NOFAS website on the webinars section, along with a recording of the video recording of the webinar. And before we get to a few questions, we have about 15 minutes for questions. Just like to remind people, if you're not already signed up to the NOFAS Weekly Roundup email newsletter, to definitely go ahead and do that on going to the NOFAS website. There's a link, a button there to sign up. It comes out once a week every Monday with many articles, news stories, the latest research, the latest FASD community news and that sort of thing, events, webinars. And also to please connect with NOFAS on social media, on our Facebook and Twitter and YouTube, where this video of this recorded webinar is going to be posted. So some of the questions that have come in, somebody was asking about some details about housing, what sort of housing is effective for people with FASD, and if there's some tips on accessing that.
Yeah, I think that's a great question. That's not an area that I have a lot of expertise in. I know I've seen some postings or different things online about people that have really banded together to create housing. But just sort of thinking about some of the things I know that are helpful for people with FASD, I think ultimately, finding the right kind of balance for the person with FASD, where they where their needs can be met, and that the people who are supporting them understand FASD and are putting in place the kinds of accommodations that are helpful. So, helping them with things like, managing their schedule and arranging, their items and things so that they can find them. Helping them, communicate with other folks. I mean, so I think it's less about the specific setup of a given house, because I think there are a lot of different ways that it could look, because there's such a range of people. Just like with a school, there's not one specific perfect school setting for a person with FASD. I think you have to really individualize it for each person. But I think ultimately, whoever is supporting that person needs to understand about FASD, needs to, doing things like reframing and accommodations are ultimately what's going to be most helpful.
All right, great. Thank you very much. And we had a question about from a parent of a infant with FASD, 20-month-old, asking about if there are anything specifically set up for people with FASD 18 months to 4 years old, around in that age range. Yeah. And specifically, they were saying that their child is not comfortable with their parents holding him or touching him, as like sensory issues, wondering if that, what the relationship of that and FASD is.
Yeah, sensory issues are really common in people with FASD, and what they're describing, what that parent's describing, is definitely something that other parents have also experienced in terms of that specific type of sensory profile. And like as I said before, kids and adults with FASD are quite variable. So some children with FASD show difficulty and uncomfortable being held, but others have the opposite pattern where they like to be held a lot and get a lot of sensory input. But I think overall sensory problems are really common. And so in some of the, there have unfortunately only been a couple of studies done with toddlers and infants with FASD, and several of those, a couple of those have really focused on the relationship between the parent and toddler or infant, and really thinking about helping promote really strong attachment between the parent and child, that the parent is responding to the child in the most effective way. There's also been a study in progress that I don't think is published yet, but it's also really focused on parents learning ways to kind of help the child regulate, and sort of those early basic self-regulation approaches, which I think would probably be most important for that kind of age range, because those are the types of skills that you're expecting young infants and toddlers to be developing, that attachment with a caregiver and kind of that early self-regulation and soothing skills.
Great, thank you. And another question from a parent. This one is a parent of a 17-year-old that is in need of a transition plan as they're planning to graduate from school, asking about ways of finding FASD-informed people that are able to coordinate services in their local area.
Yeah, that can be hard. I think, I think the NOFAS website, where it has different resources by state, is a good place to start, and looking at who's there. And then sometimes it's making, looking at the list and who's available and contacting that person and seeing who else they might know. There's also some Facebook groups or other listservs that may be relevant for different areas, that you can ask other parents who they found helpful. And another approach is I think if you can find somebody, a provider who really wants to learn and is motivated to help your child, I think that can also go a long way. Someone who's really motivated, I wish that there were people you could just go to who were experts, but that's not always the case in different communities. And so finding the person who's willing and wants to learn and will put in the time and, read the resources that you share with them, but who has the skill of the transition piece that just needs to put the FASD piece with it, that can make some good headway as well.
All right, great.
It's not the solution, but unfortunately, practically, that might be the solution for some people.
Great, thank you. And another from another parent. This one, they're part of a 21-year-old who was diagnosed at age 5, and who they characterized as being in denial of having an FASD, and they were asking, is there some way, strategies of getting this person to join a support group or take advantage of services?
So let me just make sure I heard the question right. There was a little feedback. So it's a person who was diagnosed at age 5 and now as a young adult is in denial that they have FASD and are resistant to getting support and services. Is that right?
Yeah, that's right. And it sounds like this parent is looking for them to be part of a support group.
Got it. Yeah, that can be a tough situation, and I know that there are other parents who've been in that situation in some of our local groups. I think sometimes, finding someone who that person really connects with and is seen as a support, whether that be a coach or like a supervisor at work, or an extended family member or somebody that has a positive relationship with that person, may be able to kind of help nudge them a little bit. And I think some of it's just having an open discussion. It's just tricky. I mean, the person is going to have to at some point want that service and want that support. I know one family that I know here that's been in that situation, often felt frustrated with her daughter in those moments where her daughter wouldn't seek help or, would refuse to do supports. But then there was, a moment where that window opened, where the daughter was starting to feel frustrated that things weren't working out for her and maybe she lost another job. And during those windows, there was the opportunity where the daughter was like, you know what, I think I would be open to seeking help. And so in that moment, she would be like, oh, well, here's this place I found. Would you be interested in that? And that ended up working out for a while. So I think sometimes it's looking for the windows, also finding just other support people, because sometimes if it's not your parent telling you to do something, you might be more open to it at that age. That's some of my ideas.
All right, great, thank you. And we had questions, somebody asking when the app will be available for caregivers.
Mm-hmm. Yeah, so the app will take us these things can take a while to develop, especially when done in a very systematic, careful way. So I would anticipate it's going to take us about 1.5 to 2 years to really develop it well and get feedback from people and really make sure it's meeting the needs well. Then we'll have, our plan is to have a trial to first test it to see if that works. And we'll be advertising likely through NOFAS when that study opens. So in 1.5 to 2 years, take a look. And when you see advertisements, if you're interested in participating in the study, we would invite you at that time to try it out if you're interested. And ultimately, we hope that things that are helpful we can get out to people, but we really want to make sure and test them first, not to have things that don't really work or aren't good for people out there. But there are existing groups and things already online that people can take advantage of now and supports and find in the meantime.
Great, thank you. And we had a question about asking what parents can do in their local communities to help spread awareness about FASD and educate service providers, educators in their area.
Yeah. It kind of depends on your area. In our area, for example, when I first moved to Rochester, there weren't, there was a great local parent support group, and that was the extent. There weren't any diagnostic or intervention services here locally. And so part of it was, meeting with that group, partnering with them, seeing what they were interested in. And then, it takes a lot of footwork and a lot of, talking to people. And at that stage, I would go to other clinicians or other agencies and say, hey, would you be interested in a presentation on FASD? And so then I would come and present on it. And then, over the years, the more, I think it's just kind of getting out there, getting on the radio, getting on, meeting with people. And, as you meet with more and more people, sometimes it snowballs. Like, so at this point, after being here about 5 or 6 years, I've started getting requests to come do talks. I get agencies. You find one person, there was a clinician that that I worked with, a child who he was also a provider for, and he really saw the benefit of learning about FASD. And so then he went back to his agency and advocated for the whole agency learning about FASD. And so they invited me out, and he subsequently moved to another agency later, a couple years later, and did the same thing and trying to educate that. So some of it's just finding the influential people that can be champions. And it doesn't have to be a provider. It could be parents who are, advocating and, finding a support group, whether it be, it doesn't have to be an FASD support group. Maybe they're involved in a foster care support group and say, hey, I think it could be helpful for people to learn about FASD, and either presenting it on themselves or getting other people to come out. And just kind of trying to, have a grassroots movement where getting people involved and wanting to learn about it. That would be probably my best advice on that.
Okay, great. Thank you. And we're getting close to 3 o'clock, and we have some additional questions. And just, is there Christie, would you like to give people an option to contact you if they have additional questions?
Sure. People, I think the easiest way is to email me. I don't know if my email's, I know my email's available online, but it is just my first name dot last name at rochester.edu. So Christie.Petrenko at rochester.edu, and you can send me questions. And I'm not going to be able to answer questions on email generally about, a specific child, for example, like giving advice on, treatment type things. But if you have questions about research, or if there's something I can answer more generally, I can definitely respond to that.
Okay, great. Thank you. And if we just have time for a few additional questions. Somebody was asking about their adult son that lives in a host home, asking if you have any suggestion on ways to prevent that person from stealing within that home.
Yeah, stealing can be a challenge. We've definitely worked with some younger kids in particular too who have difficulty. And I like to think about it as, first, I think it's important to kind of reframe where that kind of stealing behavior is coming from. And I think a lot of times for people with FASD, there's often two things involved. One is sort of limited understanding of ownership. So I've worked with some people who, if the person is not actively using it, kind of see it as fair game. And there's also often difficulties with impulsivity. So seeing something that you like and taking it. So for example, there was an adolescent girl we've worked with who was at another classroom, and someone's iPod was sitting out. And so she took it and really liked the case and things going on it. And then later realized, ooh, maybe I shouldn't have done that, but didn't have the best problem solving skills on how to solve that problem. And so generally when kids are taking things that aren't theirs, there are kind of 3 things that we focus on. One is increased supervision and sort of preventing things. So not having a lot of stuff, like I wouldn't leave iPads around, or things like that, having a place for things so that they're less likely to be taken, and also having people that are sort of monitoring that. Also doing explicit skill building about, having conversations in a supportive way about how, not to take the, kind of explaining that, this isn't yours. and that when someone's not using it, it doesn't mean that you can touch it. And then I think ultimately, because of the weaknesses in problem solving, I think, you know, putting in a non-punitive system where if someone impulsively takes something and realizes later that maybe that wasn't such a great idea, that they have a safe person that they can go to and say, hey, I made a mistake. Let's help me solve this problem. And so that person, their support person, would help them figure out a way to get it back to the person that it belongs to in a way that, you know, acknowledges the issue, but without being overly punitive. Because the more punitive people are, the more likely and the better at people with FASD are going to be at hiding it, and it kind of gets more insidious. So the more you can kind of make it like, oh, we made a mistake, let's see if we can solve this problem. That tends to work out better for everybody.
All right, thank you very much. And so as we're right around 3 o'clock, we'll have one final question here. And if you have additional questions, definitely feel free to reach out to the presenter, Christie Petrenko, directly, or reach out to NOFAS with additional questions. And that question is, how do you get a parent or others perhaps to recognize the condition being FASD and not some other condition like ADHD?
Like in a diagnostic content, or like if you're a parent and you suspect your friend's kid may have FASD kind of thing. Is there clarification there?
It sounds like it's, yeah, for somebody that you know, maybe that you suspect that it may be FASD related.
Yeah. I mean, that's kind of, it's a tricky question, given that, you know, some of it depends on your relationship with the person. And, you know, the facial features, for example, of FASD are fairly subtle, and there are other things that can, you know, look like that potentially if you don't know how to measure them explicitly. So there is always that risk of assuming that it might be prenatal exposure when it's not. But I think you can also, you know, if it's someone that you know fairly well, or you might, you know, have a good relationship with, you can always ask, like, you know, you could think about it from the person and ask if they've ever had concerns about their kid's behavior, or, you know, and if they had ever thought of other diagnoses, or if they knew about prenatal exposure, if there might be something going on, and kind of start the conversation that way, or share their experience. Otherwise, you know, you don't want to go up to someone you don't know and be like, I think your kid has FA. I mean, you just have to think about the relationship that you have with the person and the best way of approaching it with that specific person. I don't know.
Great. Well, thank you very much. Thank you very much, Christie. That was a great, very, very helpful presentation with a lot of great information, great research. I think a lot of people found it very helpful. And the video of the recorded webinar, again, is going to be available on the NOFAS website, along with the slides. And definitely feel free to reach out and contact NOFAS or the presenter if you have additional questions. And thank you very much. Is there anything you'd like to add, Christie?
No, I just thank everyone who participated in the call, and hopefully that it was helpful and interesting.
All right, great. Thank you. Thanks, everybody.